So I want you to imagine a newborn baby.
Okay.
They have just been delivered,
Right.
right? And it was this incredibly grueling, super complicated labor.
Yeah, those can be terrifying.
Exactly. The parents are totally exhausted,
Mhm.
they are relieved, and they were just waiting for that first cry.
Right, that moment of relief.
But then the pediatrician comes over to examine the child, and they notice something just deeply unsettling.
What's wrong with the baby?
Yeah. The baby's left arm isn't moving normally at all. I mean, it's actually hanging completely limp right at their side.
Oh, wow.
And it's aggressively twisted inward. The elbow is locked, totally straight, and the palm is facing backward.
Like they're hiding something.
Yes. It looks exactly like a waiter, subtly holding their hand behind their back, just waiting for a tip.
The classic waiter's tip posture.
Right, but here is the crazy part. The baby's arm isn't broken.
No fractures.
0 fractures. The muscles themselves are completely healthy. Actually, the trauma didn't even happen to the arm at all.
It happened somewhere else entirely.
It happened way up in the neck. Welcome to the deep dive.
It's such a profound mechanical mystery, if you don't actually know the underlying wiring.
Right, it just looks like magic or a curse.
But once you understand the circuitry, that tragic posture makes absolute mathematical sense.
And that is our mission today. We are tackling a topic that honestly strikes fear into the hearts of medical students, surgeons, and anatomy nerds everywhere.
Oh, absolutely. It's notorious.
We're going to map out the brachial plexus.
It's a beast.
It really is. So let's unpack this, because if you look at a textbook illustration of this structure,
It's a nightmare.
it looks like absolute chaos. It's this terrifying, tangled web of, yellow fibers strung between the neck and the shoulder.
Yeah, people always try to use these confusing metaphors for it.
Exactly. But we are going to throw all those away today. We aren't going to talk about trees or bowls of spaghetti or highways.
Good, because honestly, those metaphors completely fail to capture the sheer engineering precision of what we're actually looking at.
Right. We are going to look at this purely as an electrical grid.
A biological circuit board.
Yes. Every single movement you make with your arm, from throwing a knockout punch to just delicately threading a needle.
It all relies entirely on this specific power grid.
And by the end of this conversation, you, and I mean you, the person listening to this right now, are going to understand exactly how your own circuitry is routed.
You'll know exactly why sleeping wrong on your arm causes your wrist to just drop limply.
Or why a paper cut in the wrong spot can completely ruin your ability to pinch your thumb.
Yeah, we are going to build this grid logically, starting right from the power plant and tracing the cables all the way down to the end effectors in your fingertips.
So let's start at the source, the power plant, the roots.
Right.
The electricity powering your entire upper limb originates in your spinal cord, specifically down in your lower neck.
We're talking about 5 massive, crucial cables emerging from the cervical spine.
The spinal nerve roots, C5, C6, C7, C8, and T1.
And we really need to be precise about where these roots are physically emerging in your body.
They don't just float around freely in the neck, right?
No, not at all. They are tightly packed into this very specific, highly fortified anatomical corridor.
So if you are listening to this, I want you to reach up and gently press your fingers right into the side of your neck, just above your collarbone.
Yeah, feel around in there. Deep under the skin and the fat, you have these 2 dense pillar-like muscles.
They're called the scalenes, right?
Exactly. Specifically, the scalenus anterior and the scalenus medius.
So these 2 muscles are basically standing vertically, like 2 thick columns supporting the neck.
Like structural pillars. And those 5 vital nerve roots, C5 through T1, are sandwiched directly between them.
Just squeeze right in there.
Yeah, they squeeze out from the spine and emerge right through that incredibly tight slit between the 2 scalene muscles.
I mean, that seems like a really vulnerable place to put the main breaker box for the entire arm.
Oh, it is. It's a huge design flaw, honestly.
Really?
Well, think about it. If those scalene muscles spasm, or if they get hypertrophied-like, they grow too large.
How does that happen?
Say you have someone who breathes really heavily using their accessory neck muscles, like a chronic asthma patient.
Oh, so they're constantly working those neck muscles just to get air.
Exactly. Those muscles get huge, and they can clamp down and physically crush the nerve roots between them.
Wow. So they're crushing their own power plant.
It's a condition known as thoracic outlet syndrome.
And what does that feel like for the patient?
You get this awful pain, numbness, and tingling shooting all the way down the arm, and it's simply because the cables are being pinched at the very source.
That is wild. Now, before these 5 distinct cables even have a chance to, like, mix together to form the rest of the grid,
They start doing some work right away.
yeah, they start sending out dedicated wires, direct branches straight off the roots.
It's like having a dedicated power line running straight from a dam to a specific factory, totally bypassing the main city grid.
So the body prioritizes certain foundational structures.
Yes, exactly. For instance, straight off the C5 route, you get this wire called the dorsal scapular nerve.
And what does that power?
It powers the rhomboid muscles. Those are ones that pull your shoulder blades together when you puff out your chest.
Oh, okay. But there's an even more critical one,
We're
right?
much more critical and far more vulnerable dedicated wire. And this one draws power from C5, C6, and C7 simultaneously.
Oh, I remember the classic medical mnemonic for this one.
Let's hear it.
C5, C6, C7. Keep your wings from heaven.
That's the one. It refers to the long thoracic nerve.
Let's talk about why this specific nerve is so fascinating, because I read a really interesting case study about this in our sources.
Yeah, it's a very dramatic clinical presentation.
So imagine a 28-year-old patient walks into the clinic complaining of severe shoulder weakness.
Okay.
And they mentioned they recently recovered from a really bad viral infection like glandular fever or something.
Right, Epstein-Barr virus, something like that.
Exactly. The infection is completely gone. But when you ask them to push against a wall with both hands,
This is where it gets crazy.
the shoulder blade, the scapula on one side, just physically violently detaches from the contour of their back.
It sticks straight out.
Yeah, it sticks out like a little angel wing.
The clinical term for that is winging of the scapula. And when you see that in an exam room, you instantly know the long thoracic nerve has totally failed.
But why?
Right.
What is the mechanical reality there?
Well, the shoulder blade is essentially a free-floating bone.
Right, it doesn't have a big ball and socket joint holding it to the ribs.
No, it just glides over the rib cage. So to keep it from literally falling off the body, it relies on this massive fan-shaped muscle called the serratus anterior.
So the serratus anterior is acting like a biological seatbelt.
A very active, very strong seatbelt. It tightly hugs the shoulder blade flat against the rib cage.
And let me guess, the sole source of power for that seatbelt is the long thoracic nerve.
You got it.
Wait, if this nerve comes off the roots all the way up in the neck and the muscle it powers is down on the ribs,
It has to travel a really long way.
that is a massive distance for a single nerve.
It is. It drops almost vertically straight down the side of the chest wall. And because it's so long and travels right over the outside of the ribs, it is incredibly exposed.
Which brings us right back to our 28-year-old patient. A virus wouldn't physically cut the nerve.
No, a virus doesn't have a scalpel.
So what's actually happening in that scenario?
It's an autoimmune crossfire. The condition is often diagnosed as Parsonage-Turner syndrome.
Autoimmune crossfire.
Yeah. So the patient catches a virus, like glandular fever. Their immune system mounts this massive aggressive defense, producing antibodies to destroy the virus.
Makes sense.
But in rare cases, those antibodies get totally confused. The molecular structure of the virus happens to look very, very similar to the molecular structure of the myelin sheath.
Oh no, the myelin sheath is the protective insulation wrapping around the long thoracic nerve, right?
Exactly. It's the rubber coating on the wire.
So the immune system attacks the electrical insulation of the patient's own wiring.
Precisely. It literally strips the insulation away. So the electrical signal coming from C5, C6, and C7 just shorts out before it can ever reach the serratus anterior.
The muscle loses power,
The seatbelt unbuckles.
and the shoulder blade pops off the back.
Uh-huh.
That is wild,
You can also see this mechanically in the trauma bay, too.
like from a car accident.
Yeah, a direct, violent blow to the ribs can literally crush the nerve right against the bone.
Ouch. But either way, the diagnostic logic is just undeniable. Winged scapula equals long thoracic nerve failure.
Every single time.
Okay, so we have our 5 main roots, C5 to T1, squeezing between the scales, throwing off a few dedicated wires like the long thoracic.
But the system doesn't stay as 5 parallel cables for very long.
Right. As the nerves travel slightly further down into the base of the neck, they begin to merge together.
We go from 5 roots to 3 thick cables, which we call trunks.
Let's map that convergence out. It's actually pretty simple math.
It is. The top 2 roots, C5 and C6, they merge to form the upper trunk.
Okay, top 2 make the top trunk.
Right. And the bottom 2 roots, C8 and T1, they merge to form the lower trunk.
Bottom two make the bottom trunk.
And the middle root, C7, it just continues straight on all by itself as the middle trunk.
Okay, this is where I really want to pause and look at the engineering philosophy of all this.
The philosophy of the plexus.
Yeah. Because if I'm designing a machine, right, and I need to send a signal from the neck all the way down to the fingertips.
Why bother merging the wires together?
Exactly. Why not just run 5 straight cables all the way down to the hand? Missing the signals just seems like it makes the whole system needlessly complicated.
If you view it purely as a simple wiring diagram, yeah, it looks super messy.
It looks like a mistake.
But if you view it through the lens of evolutionary survival, it is an act of pure, unadulterated genius.
How so?
It is the biological equivalent of a decentralized power grid.
Decentralized. Okay, break that down for me.
Think about the physical vulnerabilities of the human cervical spine. We are constantly twisting our necks, right?
Yeah, checking blind spots, sleeping weird.
Taking impacts in sports, developing bone spurs as we age, or herniating spinal discs.
So the neck takes a lot of abuse.
A ton. So let's say you suffer a severe disc herniation in your neck, and it completely crushes the C6 spinal root.
Just totally flattens it.
Right. The power from C6 is totally cut off at the source. Now, if C6 was a single, straight, isolated wire controlling your entire thumb,
Oh, I see. You would permanently lose your thumb.
it would be permanently paralyzed. Gone.
But because it's a grid.
Because C6 immediately merges with C5 to form the upper trunk, the downstream muscles aren't relying on a single point of failure anymore.
The electricity mixes together in that trunk.
Exactly. Further down the line, a single muscle in your forearm is going to receive a composite nerve that contains fibers from C5, C6, and maybe even C7.
So if C6 dies at the spine,
The muscle might get a little weak, sure, but doesn't shut down completely. The other roots subsidize the power deficit.
that is amazing. The trunks are essentially massive junction boxes designed to ensure redundancy.
It's an incredible insurance policy for the limb. It completely sacrifices simplicity for survivability.
Okay, so let's look at exactly where these 3 massive junction boxes, the trunks, are physically sitting in the body.
Right, they've moved down from between those scalene muscles in the neck.
Where are they now?
They're resting directly on top of the very first rib,
The first rib, that's pretty high up.
very high, and they are lying snugly posterior to or behind the subclavian artery.
And that artery is the main blood vessel pumping oxygen to your arm.
Exactly.
So they're essentially crossing the threshold from the neck into the chest and shoulder cavity.
They are. And this specific location, resting right on that first rib, creates a terrifying clinical trap.
I read about this in the notes. This is specifically a trap for that lower trunk, right? The one carrying the C8 and T1 fibers.
Yes. It's a spatial vulnerability that literally every physician has to memorize for their board exams.
Because of what is sitting directly underneath that first rib.
Right. What anatomical structure is directly below it?
The lung. So basically the very top peak of the lung, the apex.
Exactly. And most people don't realize this, but the apex of the lung rises up surprisingly high into the base of the neck.
It actually pops up above the collarbone a little bit, doesn't it?
It does. It completely fills the dome of that first rib, which means the fragile lung tissue is practically touching the lower trunk of the brachial plexus.
Okay, so consider a patient who has been a heavy smoker for 40 years.
A classic high-risk patient.
They develop a malignancy, a tumor, right at the apex of their lung.
This is called a Pancoast tumor.
Because it's at the very top of the lung, it doesn't really have a lot of room to grow downward into the airy space.
No, tumors take the path of least resistance, or in this case, they just push upward.
It grows upward, pushing right into the rigid bone of the rib.
And as it invades upward, what is the very first soft tissue structure it hits and begins to crush against the bone?
The lower trunk of the brachial plexus.
Yeah.
The C8 and T1 nerve fibers.
Exactly.
So a patient could literally walk into your clinic complaining of deep burning pain, numbness, and severe weakness in their hand.
Right, specifically in their little finger and the tiny muscles of the palm, because those are all wired by C8 and T1.
They might just think they have carpal tunnel syndrome, or like a pinched nerve in their elbow.
Sure, that's what everyone assumes. But the physical exam of their actual arm shows absolutely nothing wrong.
Because the short circuit isn't in their arm at all.
It isn't even in their neck. The hand is acting as a remote alarm bell for a lethal lung cancer.
That is deeply chilling. The hand is telling the story of the lung.
This condition is known as superior sulcus syndrome. And I tell you, if you don't possess this architectural blueprint in your mind,
You'll miss it entirely.
you will spend months injecting the patient's wrist with steroids, treating carpal tunnel that doesn't exist, while the lung tumor silently metastasizes.
The geography of the nerves is literally the diagnosis.
That's the beauty and the terror of anatomy.
Okay, moving down the grid, we have our three trunks, upper, middle, and lower. They are crossing over the first rib, and they slide behind the middle third of the clavicle, your collarbone.
Right.
And right as they pass behind the collarbone, the architecture changes all over again.
It gets more complex. Every single one of those three trunks splits perfectly in half.
They divide.
They divide into an anterior division and a posterior
So
division.
the three trunks suddenly become 6 divisions.
3 anterior, 3 posterior.
And I've got to say, this is the part of the diagram where I think most people's brains just totally blue screen.
Oh, yeah. It just looks like random shuffling of wires.
It really does. But there is a profound, deeply functional logic to why the body does this exact split right behind the collarbone, isn't there?
It is the ultimate biological sorting mechanism.
A sorting hat for nerves.
Exactly. And to understand why it happens, you actually have to look backward at human embryology.
Oh, going back to the womb.
Way back. When you were just a tiny embryo, a few weeks old, your arms didn't even exist yet.
What do we have instead?
You just had these little fleshy paddles called limb buds growing out of the sides of your body.
Like little flippers.
Like little flippers. And the cells in those flippers were already organizing themselves into 2 totally distinct camps.
Okay, what were the camps?
The cells on the front side of the flipper, the ventral side, they were genetically programmed to become flexor muscles.
Muscles that bend your joints.
Right. And the cells on the back side of the flipper, the dorsal side, they were programmed to become extensor muscles.
Muscles that straighten your joints.
Exactly. So the front bends, the back straightens.
That's a nice, simple rule.
But now the nervous system has to wire those growing muscles. It has to send cables from the spine all the way out into this growing flipper.
And it would be incredibly inefficient to just send a jumbled mess of cables down the arm and have them randomly search for the right muscles.
It would be disaster. So instead, the brachial plexus does all the sorting early on, right behind the collarbone.
Let me guess. The anterior divisions are gathering all the flexor cables. And the posterior divisions are gathering all the extensor cables.
You got it perfectly. The body is deliberately separating the benders from the straighteners.
Wow.
Every single anterior division is destined to supply the front of your arm. Every single posterior division is destined to supply the back of your arm.
It is literally routing the current based purely on function.
It's not chaos at all. It's a highly organized distribution center.
That makes so much sense. So we are behind the collarbone, and the wires have been sorted into front and back.
Right. But they don't stay as 6 separate wires for very long.
Of course not. Because as they plunge down past the collarbone and actually enter the axilla of the armpit, they recombine one last time.
They merge into 3 massive final bundles. We call these cords.
The cords, the lateral cord, the posterior cord, and the medial cord.
And the naming convention here is vital because they are not named based on their relationship to the bones or the muscles.
What are they named after?
They are named strictly based on their physical relationship to a massive pulsating tube running right through the dead center of your armpit.
The axillary artery.
Yes. If you press deeply into your armpit right now, you can actually feel this artery throbbing.
It is the main pipeline of blood for the whole arm.
And those 3 final nerve bundles wrap themselves intimately around that artery.
So the lateral cord sits on the outside, lateral to the artery.
Correct.
The medial cord sits on the inside near the ribs.
Yep.
And the posterior cord sits directly behind it.
Exactly. Now let's look at the math of how these cords are actually built, keeping that bender versus straightener embryology rule in mind.
Okay, let's look at the straighteners first, the posterior divisions.
This is honestly the easiest math in the entire plexus.
Thank goodness.
All 3 posterior divisions from the upper, middle, and lower trunks, they all just gang up together.
They all merge.
They merge into one giant super cable, the single posterior cord.
So the back of the arm is completely handled right there. One massive conduit for every single extensor muscle sitting right behind the artery.
It's beautifully simple.
But what about the anterior divisions, the benders?
They form the remaining 2 cords. The anterior divisions from the upper and middle trunks join forces to become the lateral cord.
Okay.
And the anterior division from the lower trunk just continues on all by itself to become the medial cord.
Wait, let me trace that out in my head. That means the front of the arm, all the flexing power, is getting its electricity exclusively from the lateral and medial cords.
Yes.
And the back of the arm, all the extending power, is wired exclusively by the posterior cord.
The distribution is flawless. What looked like spaghetti is actually a perfectly organized dual-channel circuit board.
Flexors on the sides, extensors in the back. I love it.
It's elegant.
Okay, so we have built the main grid. We are deep in the armpit. Now we have to look at where these massive cords finally plug into the muscles.
Right, the end effectors.
Let's trace the terminal branches. We'll start with the straighteners, the posterior cord.
Okay.
It's sitting deep in the armpit. It's packed with fibers from C5 all the way down to T1. What are its major deliverables?
Well, it gives off a few smaller branches to the muscles of the shoulder blade, like the subscapular nerves and the thoracodorsal nerve, which powers your lats, the latissimus dorsi.
The big pulling muscles.
Right. But the two major terminal cables we really need to focus on are the axillary nerve and the radial nerve.
Let's follow the axillary nerve first, because this nerve basically takes an immediate exit right out of the armpit.
It doesn't travel down the arm at all.
It carries primarily C5 and C6 fibers, and it takes a very sharp, honestly, somewhat treacherous path backward.
Yeah, it dives right through this tight little anatomical window made of muscle and bone.
Called the quadrangular space.
Exactly. And once it slips through that little window, it physically wraps itself horizontally around the surgical neck of the humerus.
The humerus being the upper arm bone, so it's literally strapped right against the bone.
Tightly strapped. And its primary job, once it wraps around that bone, is to plug into the deltoid muscle.
The massive, thick muscle that caps your shoulder.
The one that gives you that broad-shouldered look. Its main job is to lift your arm straight out to the side, which we call abduction.
It also supplies a smaller rotator cuff muscle called the teres minor.
It does. But mechanically speaking, if the axillary nerve is strapped directly to the surgical neck of the humerus,
here comes the clinical trap.
what happens if a patient falls off a ladder, lands really hard on their shoulder, and fractures that exact part of the bone?
The jagged edges of the broken humerus are going to instantly shear or crush the axillary nerve. It is right in the crossfire.
Exactly. It gets shredded.
So the deltoid loses power.
Yeah.
The patient can't lift their arm.
They will have profound weakness, yes. Though, to be biomechanically precise here, the deltoid doesn't actually initiate the lifting of the arm.
It doesn't start the movement.
No. The first 15 degrees of abduction, just getting the arm slightly away from the body, that is actually handled by the supraspinatus muscle.
Which is wired by a completely different nerve we talked about earlier.
Right. But once the arm is 15 degrees out, the deltoid is supposed to take over and lift it the rest of the way up.
So if the axillary nerve is cut, the patient can swing their arm out just a tiny bit, but then they hit a wall.
They hit a wall. They physically cannot raise it horizontally.
Is there a sensory clue for this? Like, does the skin go numb?
Yes, a very specific patch of skin. The axillary nerve supplies sensation to an oval-shaped area right over the lower half of the deltoid muscle.
Okay.
In the ER, we actually call this the badge area because it corresponds perfectly to where a military unit patch or a police badge is sewn onto a uniform sleeve.
Oh, that makes it so easy to remember.
Right. If you touch that specific patch of skin on a patient with a fractured surgical neck and they can't feel it, instantly the axillary nerve is compromised.
Yeah. Okay, so the axillary nerve peels off early to handle the shoulder cap. What happens to the rest of that massive posterior cord?
The remainder of the posterior cord continues straight down the arm as the radial nerve.
The radial nerve.
I call it the great extensor. It is a massive, thick cable that is single-handedly responsible for almost all the extending power in your entire upper limb.
Wow. So if you straighten your elbow,
That's the radial nerve.
if you pull your wrist back like you're revving a motorcycle, if you point your fingers straight out,
All radial nerve firing.
but because it has to travel from the armpit all the way down to the back of the hand, it's exposed to a lot of danger.
A tremendous amount of danger.
If we trace its path, it basically outlines a map of clinical vulnerabilities. There are 4 distinct danger zones where the radial nerve gets trapped or crushed.
Let's walk through them, starting right from the top.
Okay, danger zone 1, the axilla, the armpit itself.
This is the highest point of vulnerability, right where the nerve originates. And the classic clinical presentation here is known as Saturday night palsy.
Saturday night palsy. Sounds like a party gone wrong.
It usually is. Imagine someone who is heavily intoxicated. They pass out sitting in a hard wooden chair, and they slump over, draping their arm over the back of the chair.
Oh, I see where this is going.
The hard wooden edge presses deeply into their armpit for 6 straight hours while they sleep.
Or, I read about this happening with people using crutches incorrectly, right? Resting their entire body weight on the armpit pads instead of using their hands.
Exactly the same mechanism. The sustained pressure physically crushes the radial nerve against the humerus bone.
And what does that do to the nerve?
The constant compression causes ischemia. It literally starves the nerve of blood flow and the myelin insulation degrades.
Wow. And because the damage happens so high up on the power grid?
You lose power to every single extensor muscle downstream.
So what does that look like when the patient wakes up from their bender?
Total extensor collapse. In medicine, we describe it as 3 distinct drops.
3 drops. Break them down.
First, they lose the triceps, so they have an elbow drop. They literally can't straighten their arm.
Okay, elbow drop.
Second, they lose the forearm extensors, so they have a severe wrist drop. The hand just hangs limp, kind of like a swan's neck.
Wrist drop. And the third?
They lose the finger extensors, so they have a finger drop. 3 drops. Plus, they lose sensation down the entire back of the arm and the back of the hand.
Total devastating failure of the back of the arm.
Total failure.
Okay, let's say the nerve survives the armpit. It continues down the arm. Danger zone 2, the spiral groove.
Right. As the radial nerve moves down the upper arm, it does something really unique. It needs to get from the inside of the arm to the outside.
And how does it cross over?
It wraps around the back of the humerus bone in a very tight spiral. It sits directly in a shallow trench carved into the bone itself called the spiral groove.
So it's exposed right against the hard shaft of the bone. Let me guess. Mid-shaft humeral fractures.
Yes, very common. If a patient is in a car accident or gets struck by a heavy object and the middle of their upper arm bone snaps, the radial nerve is dragged right across the sharp fracture fragments.
It's just sitting right there in the groove waiting to get cut.
Exactly.
But the clinical presentation here has to be different from the armpit crush, right?
Yeah.
Because the nerve is damaged further down the line.
Exactly. And this is where the anatomical logic is just so satisfying. When the radial nerve is crushed in the spiral groove, the patient will present with only 2 drops.
2 drops. They will have a wrist drop and a finger drop.
Correct.
But the elbow is fine? They can still straighten their elbow?
They can.
Why is that?
Because the electrical branches that power the triceps muscle, the elbow straightener, those branches peel off from the radial nerve high up in the armpit.
Oh, before the nerve enters the spiral groove.
Precisely. The power to the elbow took an early exit.
So the triceps got its power before the main cable was cut by the broken bone.
Yes. So the elbow works perfectly, but everything downstream from the fracture, the wrist and fingers, is dead.
3 drops means armpit injury. 2 drops means mid-arm fracture. That is brilliant logic.
It's pure wiring.
All right, moving down. Danger zone 3. The elbow. The radial nerve crosses the outside of the elbow joint and splits into 2 distinct branches.
Right. One goes deep, one stays superficial.
Let's talk about the deep one. It dives under a muscle and becomes known as the posterior interosseous nerve,
Or the PN.
the PN.
This nerve is deeply vulnerable if a patient fractures the head or neck of their radius bone. That's one of the 2 bones in the forearm, right near the elbow joint.
Okay, if the PN is sheared by a radial neck fracture, what does the patient lose?
The deficit is hyperspecific. The PN powers the muscles that straighten the fingers and a muscle called the supinator, which turns your palm upward.
So the patient will complain of deep, aching pain when they try to twist their forearm.
Yes, and they will have a finger drop. They physically cannot straighten their fingers.
But they don't have a wrist drop.
No, they don't.
Why not?
Because the specific muscle that yanks the wrist back, the extensor carpi radialis longus, it receives its wiring before the radial nerve splits at the elbow.
Amazing. So the wrist works, but the fingers drop. We've gone from 3 drops to 2 drops to 1 drop.
Exactly.
And what about sensation? Do they have numbness on the back of their hand?
This is the massive diagnostic trap. They will have absolutely no numbness, 0 sensory loss.
Wait, why? The radial nerve provides sensation to the back of the hand.
True, but remember when the radial nerve split at the elbow? It segregated its fibers.
Oh, I see.
It sent all its motor power down the deep PI, and it sent all its sensory fibers down the superficial branch.
So if you cut the deep branch, you only lose movement. The skin feels perfectly normal,
You got it.
which perfectly sets up our final danger zone 4, the wrist.
Right.
The superficial branch of the radial nerve, the one carrying all that sensory data, it travels down the forearm and crosses right over the wrist, very close to the skin.
It is so close to the skin that it can be damaged by something as simple as wearing a wristwatch way too tightly.
Are you serious? A wristwatch?
Yes. Or, much more commonly in the ER, a laceration from broken glass, or handcuffs that have been ratcheted down too hard by the police.
Handcuff neuropathy. Is that a real thing?
Handcuff neuropathy is a very real phenomenon.
Wow, so if that superficial branch is crushed by handcuffs, what's the deficit?
It's the exact inverse of the elbow injury. You have zero motor loss. The muscles in the hand are totally fine because they've already been powered by other nerves.
The patient only experiences sensory loss.
Specifically, a patch of numbness or burning pain right over the web space on the back of the hand between the base of the thumb and the index finger.
It is an incredible cascade of logic. The higher the injury on the grid, the more collateral damage. The lower the injury, the more specific and isolated the deficit.
Exactly.
That entirely covers our straighteners, the posterior cord. Let's flip the arm over and look at the front, the benders.
Time to trace the terminals from the lateral and medial cords.
Let's start with a major branch peeling off the lateral cord, the musculocutaneous nerve.
As the name heavily implies, it has a dual purpose. It powers muscles, and it provides cutaneous sensation to the skin.
It takes a very direct, brutal path, doesn't it?
Very direct. It literally pierces straight through the belly of a muscle in the armpit called the coracobrachialis. It just punches right through the meat of it.
Like threading a needle through a steak.
Basically, yeah. And then it runs right underneath the biceps muscle.
And it serves as the primary power source for the biceps and the brachialis muscles. These are your primary elbow flexors.
Right. So if a patient suffers a deep, penetrating knife wound to the upper arm that severs the musculocutaneous nerve, the flexor system fails.
The triceps on the back of the arm are suddenly unopposed.
Exactly. The patient will have profound weakness when trying to bend their elbow against resistance.
And because the nerve finishes its journey by piercing out to the skin.
They will also have a strip of numbness running right down the lateral or outer edge of their forearm.
Okay, that handles the upper arm benders. Now we arrive at the absolute heavy hitters of the forearm and the hand. Let's trace the median nerve.
Ah, the median nerve.
This is the great flexor, the great pronator. It is constructed from roots from both the lateral and medial cords, meaning this massive cable carries fibers from C5 all the way down to T1.
It is an absolute powerhouse.
And as it travels down the upper arm, it runs closely alongside the brachial artery. In fact, it does a very specific anatomical lane change.
It does. It starts out sitting on the lateral side of the artery on the outside, but as it travels down toward the elbow, it diagonally crosses in front of the pulsating artery to end up on the medial side, the inside.
I mean, that seems incredibly dangerous. It's essentially weaving through high-traffic real estate.
Oh, it's very dangerous. And as it crosses the elbow and dives into the forearm, it encounters a series of severe clinical traps.
Let's look at the first major one. I know we see this frequently in pediatric trauma.
Yes. Picture an 8-year-old child climbing on monkey bars. They slip and fall, and they throw their hand out to catch themselves.
Natural reflex.
Right. The force travels straight up the locked arm, and the humerus bone snaps just above the elbow joint.
A supracondylar fracture.
Yes, but the bone doesn't just neatly crack. The sharp, jagged lower fragment of the bone gets violently shoved backward by the force of the fall, while the upper shaft of the bone gets driven forward.
Straight into the soft tissue of the lower bicep.
Straight into that lane-changing median nerve and the brachial artery.
The jagged bone acts like a spear.
Exactly. It can stretch, impale, or completely sever the median nerve, and it can crush the artery right next to it.
So in the ER, if you examine that child, you might feel a very weak radial pulse at their wrist because the artery is kinked.
Correct. And neurologically, they will lose the power to pronate their forearm.
Pronation. Meaning if they hold their hand out like they're holding a bowl of soup, they physically cannot turn their hand over to pour the soup out.
Right. The median nerve powers the pronator teres muscle. The circuit is cut, the muscle is dead, the arm cannot twist inward.
But the median nerve's most famous, most notorious trap is further down the line. We are moving from the elbow to the wrist.
Everyone knows this one.
And here's where it gets really interesting. Carpal tunnel syndrome.
The absolute most common site of nerve entrapment in the entire human body.
Let's talk about the architecture of the wrist because it is essentially a mechanical bottleneck.
To get from the forearm into the palm of the hand, the median nerve has to pass through the carpal tunnel.
It is a literal rigid tunnel.
It is. The floor and the walls are made of the hard carpal bones of your wrist, and the roof is a thick, totally unyielding band of connective tissue called the transverse carpal ligament.
It's like a tiny subway tunnel. But the nerve isn't the only thing taking that subway, is it?
No, and that's the whole problem. The median nerve has to share this tiny tunnel with 9 thick, rope-like flexor tendons that control your fingers.
9 tendons and a nerve all jammed in there.
It is a high-traffic, incredibly overcrowded space.
So what triggers the syndrome? Why does the tunnel fail?
Anything that increases the volume inside that tunnel or decreases the space.
Like what?
Well, if you type on a keyboard with terrible ergonomics for 10 hours a day, those 9 flexor tendons slide back and forth, rubbing against each other constantly.
So they get irritated.
They become inflamed and they physically swell. Or, consider pregnancy, the hormonal changes cause massive fluid retention throughout the whole body. Fluid builds up inside the carpal tunnel.
But the bones can't expand, and that roof ligament won't stretch.
Exactly. So as the pressure inside the tunnel skyrockets, what gives way?
The softest, most delicate structure in the tunnel.
The median nerve, it gets relentlessly crushed. The tiny blood vessels supplying the nerve are squeezed completely shut, starving it of oxygen. The myelin insulation begins to break down.
What does that actually feel like to the patient?
It starts as an intermittent, maddening, tingling, burning, or numbness. But the location is highly specific to the median nerve's wiring map.
It doesn't just make the whole hand numb.
No, it will only affect the lateral 3.5 fingers.
3.5.
That is the thumb, the index finger, the middle finger, and exactly 1 vertical half of the ring finger.
Half the ring finger.
Yes, the pinky finger will feel perfectly fine.
The precision of that boundary line is astonishing.
It's razor sharp. Another classic hallmark of carpal tunnel syndrome is severe sleep disruption.
Oh yeah, the nighttime pain.
Patients will tell you they fall asleep fine, but they wake up at 3 a.m. with their hand feeling like it's on fire or completely dead. They literally have to hang their arm out of bed and violently shake their hand to get the blood flowing again.
Why does it happen at night, specifically?
Because when we sleep, we tend to curl into the fetal position. We unconsciously flex our wrists inward,
Oh, and bending the wrist dramatically compresses the carpal tunnel even further.
pushing the already elevated pressure past the breaking point.
If a patient comes to you with this, how do you prove it's carpal tunnel without, sending them for an expensive MRI?
The physical exam is paramount here, and it relies entirely on mechanically manipulating the pressure in that tunnel. We use provocative tests.
Provocative tests.
The first is valence test. You ask the patient to press the backs of their hands together, fingers pointing down toward the floor, forcing the wrists into extreme 90-degree flexion.
Like a reverse prayer.
Exactly. And you have them hold that awkward pose for 60 seconds.
You are artificially crushing the tunnel to see if you can trigger the short circuit.
Exactly. If their thumb and index fingers start buzzing and going numb within a minute, that's a positive valence sign.
What else?
Another classic is Tinel's test. You take your fingers, or a reflex hammer, and you physically tap firmly directly over the center of their wrist, right on the roof of the tunnel.
Literally tapping on a faulty wire to see if it sparks.
Precisely. If tapping the nerve sends an electrical shock or a shooting, radiating tingle straight down into their middle finger, that's a positive tunnels.
And there is Durkin's test too, right?
Yeah, Durkin's test is where the doctor simply presses both of their thumbs aggressively into the patient's carpal tunnel and holds the pressure for 30 seconds to force the ischemia.
I just love how mechanical and physical all these tests are. It's pure plumbing and wiring.
It really is.
But I read in the literature that despite all these physical manipulations, one of the most sensitive diagnostic tools requires no touching at all.
Ah, you're referring to the cat's hand diagram.
Yes. It sounds almost too simple to be true.
It does, but studies have proven its efficacy time and time again. You simply hand the patient a piece of paper with a drawing of a hand on it and a pen.
And you just say what?
You simply tell them, shade in the exact areas where you feel the numbness.
A literal coloring exercise.
Yes, because patients are incredibly perceptive of their own pain. If they shade in the thumb, index, middle, and exactly half of the ring finger, leaving the pinky totally blank,
You have your diagnosis.
you have it. A simple diagram often completely outperforms complex nerve conduction studies in early screening.
That is brilliant.
Oh,
Okay, so let's talk about fixing it. If the pressure is too high, how do you release it?
you start conservative, non-steroidal anti-inflammatory drugs like ibuprofen to reduce the tendon swelling.
Makes sense.
And critically, you prescribe rigid wrist splints for them to wear exclusively at night.
To stop them from curling into the fetal position.
Exactly. The splint physically locks the wrist in a neutral, straight position, preventing them from curling it while they sleep and crushing the nerve.
And if the conservative route fails, if the nerve is starting to permanently die,
Then you need a mechanical solution for a mechanical problem. You go to the operating room.
the surgery.
A surgeon makes an incision in the palm, exposes that thick, unyielding roof, the transverse carpal ligament, and simply slices it wide open.
You literally cut the roof off the tunnel.
You cut the roof. The pressure instantly drops to zero. The nerve can breathe. The blood flow returns.
But doesn't the roof need to be there?
Over time, the body fills the gap in the cut ligament with scar tissue, permanently expanding the volume of the tunnel. It is a highly satisfying, curative surgery.
There's one more fascinating, hyper-specific detail about the median nerve at the wrist that we have to talk about, because it highlights how microscopic this wiring schematic really is.
Oh, I know what you're getting at.
Imagine a 22-year-old bartender. They are washing glasses. A pint glass shatters in their hand, and a large shard of glass slices deeply into the very base of their palm.
Okay, right on the pinky side.
Yes, right next to a hard little bone called the pisiform.
The pisiform is that pea-sized bone you can feel right at the base of your palm, directly below your pinky. It's a major landmark.
So they slice the base of their palm right next to the pisiform. They go to the ER, get stitched up. But a week later, they realize a circular patch of skin right in the dead center of their palm is completely numb.
But, and this is the crucial part, their fingers feel perfectly fine.
Exactly. They don't have carpal tunnel symptoms, just a totally numb palm. How is that possible if the median nerve goes through the tunnel?
It is possible because of an incredibly elegant bypass wire called the palmar cutaneous branch of the median nerve.
An express lane.
Think of it exactly like an express lane. Just before the massive median nerve dives down into the claustrophobic, high-pressure carpal tunnel, it sends off a tiny, thread-like branch.
And this branch refuses to go into the tunnel.
Right. It travels over the top of the roof ligament, sitting very superficially just under the skin.
It totally bypasses the bottleneck.
And its only job is to provide sensation to the skin in the center of the palm.
So the architectural brilliance of this is revealed during carpal tunnel syndrome, right?
Yes. When the pressure inside the tunnel rises and crushes the main median nerve, the patient's fingers go numb. But the skin of their central palm remains perfectly sensitive.
Because the palmar cutaneous branch is safely riding above the tunnel, totally immune to the pressure beneath it.
Exactly.
But the downside of being an exposed superficial express lane,
Is extreme vulnerability to direct trauma.
like a broken pint glass.
When our bartender fell on the broken glass, the shard easily sliced through the thin skin and severed that superficial palmar branch, leaving the deep tunnel totally untouched.
The palm goes numb, but the fingers are spared. The geography of the laceration dictates the exact circuitry failure.
It's all about exactly where the wire gets cut.
Okay, let's look at the final terminal branch of the grid, the other side of the medial cord, the ulnar nerve.
Drawing power exclusively from the lowest roots, C8 and T1.
If the median nerve is the powerhouse of the hand, providing the brute grip strength of the thumb and index fingers.
The ulnar nerve is the maestro.
A maestro.
It is the fine-tuner. It is responsible for the delicate, hyper-complex micro-movements of the hand.
It travels down the inside of the arm, and it has its own famous clinical trap at the elbow.
Oh, yes, the cubital tunnel. As the ulnar nerve crosses the elbow, it passes right behind a massive knob of bone on the inside of your elbow called the medial epicondyle.
It sits in a shallow groove covered only by a thin layer of skin and fascia,
This is what we call the funny bone.
which is a terrible misnomer.
Terrible, because it isn't a bone at all, and hitting it is definitely not funny.
No. When you accidentally smash the inside of your elbow against a door frame, you are physically crushing the ulnar nerve directly against the medial epicondyle.
That intense, agonizing electrical shock that shoots down into your pinky finger, that is the ulnar nerve literally screaming as it forcefully depolarizes from the impact.
And just like the median nerve, the ulnar nerve travels down into the hand and splits. It provides sensation to the remaining medial 1.5 fingers, the pinky, and the other vertical half of the ring finger.
But its motor function is where it gets really complex.
Tell me about the motor function.
The ulnar nerve dives deep into the architecture of the hand to power the vast majority of the intrinsic hand muscles.
Intrinsic muscles.
These are the tiny hidden muscle bellies located entirely between the bones of your hand. They allow you to spread your fingers wide apart, like you're playing a piano octave, or squeeze them tightly together.
There's a very specific clinical scenario that perfectly illustrates the ulnar nerve's control over the thumb, right?
Yes. Let's say a butcher's knife slips. and they sustain a deep, penetrating laceration right at the base of their palm. The wound heals, but weeks later, they realize they have lost a very specific mechanical ability. They can no longer firmly squeeze their thumb inward, flush against the side of their index finger.
They have lost the power of thumb adduction.
Adduction, yes, bringing it toward the midline. And this points perfectly to the deep branch of the ulnar nerve.
Now, wait, this is a tricky concept because we just established a few minutes ago that the median nerve is the powerhouse of the thumb.
We did. The median nerve controls the muscles that let you flex the tip of your thumb, point it outward, and rotate it across your palm to touch your pinky.
But the ulnar nerve gets one specific job with the thumb.
Exactly. The ulnar nerve controls exactly one crucial thumb muscle, the adductor pollicis.
The adductor pollicis.
It is a thick, triangular muscle deep in the web space of the thumb. Its sole purpose is to act like a vice grip, pulling the thumb tightly flush against the side of the hand, locking it against the index finger.
It's the muscle you use when you are, like, turning a really heavy key in a stiff lock.
Perfect example. So if the deep branch of the ulnar nerve is severed by that butcher's knife, that specific vice grip muscle dies.
So how do you test for that in a clinic? Because the patient can still move their thumb in all these other directions since the median nerve is fine.
This is where we use one of the most elegant physical exams in all of neurology, Froment's test.
The biomechanics of this test are just fascinating.
You, as the doctor, take a flat piece of paper. You ask the patient to pinch the paper tightly between the pad of their thumb and the side of their index finger.
Like they're holding a playing card.
Exactly. But you give them a strict rule. They must keep their thumb absolutely flat and perfectly straight, no bending at the knuckles.
Okay.
You then grab the other end of the paper and try to firmly pull it away from them.
What happens in a healthy hand?
If their ulnar nerve is healthy, the adductor pollicis muscle fires. It clamps the straight thumb down against the index finger like a vise. It holds the thumb perfectly flat, and you simply cannot pull the paper away.
But what if the ulnar nerve is cut and that adductor muscle is dead?
This is where the brain does something truly incredible.
What does it do?
The brain knows you are trying to pull the paper away. It senses that the adductor pollicis is dead and failing. To stop the paper from slipping, the brain unconsciously and instantly reroutes the problem to a completely different electrical system.
It calls for backup.
It recruits a muscle wired by the median nerve to help out.
It specifically recruits a muscle called the flexor pollicis longus.
Exactly. But this muscle's job is not to pull the thumb flat. Its job is to aggressively bend the tip of the thumb downward.
So as you pull the paper,
The patient's thumb will suddenly buckle and dramatically bend at the interphalangeal joint, hooking onto the paper to try and maintain their grip.
because they can't clamp it flat, they have to hook it.
Precisely. That sudden buckling, that bending of the thumb tip to compensate for a lack of flat adduction force, is a positive Froment sign.
It is absolute proof that the ulnar nerve has failed, and the median nerve is desperately trying to cover for it.
The body automatically routes around the damage using a different wire.
That is deeply profound. It's like biological troubleshooting happening in real time.
It really is.
Okay, we've covered the individual pathways, the individual branches, and the highly specific isolated injuries. But that brings us to our final section. System failures.
The big ones.
What happens when it isn't just a single wire getting snipped? What happens when massive, thick bundles of the grid are violently ripped apart right at the source?
And more importantly, why do these massive injuries result in such strange, contorted, rigid hand postures?
Like the waiter's tip we talked about at the very beginning.
Exactly. To understand why a paralyzed arm twists itself into these bizarre shapes, we have to grasp a fundamental biomechanical concept, the principle of joint balance.
Joint balance.
It is essentially a perpetual, microscopic tug of war happening inside your body right now.
Let's break that down. Most joints in your arm, like your elbow, your wrist, your knuckles, they are held in a relaxed, neutral position.
But they aren't just dangling loosely.
Right. They're being held there because there are opposing forces pulling on them constantly.
Think of the joint as a flag planted right in the middle of a tug of war rope. On one side, you have the flexor muscles, the benders, pulling the rope. On the exact opposite side, you have the extensor muscles, the straighteners, pulling the rope.
In a healthy resting arm, the flexors are pulling with, say, 10 pounds of force, and the extensors are pulling with exactly 10 pounds of force in the opposite direction.
It's perfectly balanced tension. The flag doesn't move.
But imagine what happens if a nerve injury suddenly acts like a pair of scissors and cuts the rope on the flexor side.
The flexor muscles literally die. They drop their end of the rope. The tension isn't just reduced, it is completely 100% unopposed.
So the extensors, which are wired by a completely different nerve that didn't get damaged, are still pulling with 10 pounds of force.
Exactly. The healthy extensors are still firing perfectly, but because they have absolutely no resistance pulling against them anymore, they instantly win the tug-of-war.
They violently yank the joint all the way into a permanent, rigid state of extreme extension.
This is a massive shift in perspective for most people. The resulting deformity, the twisted, rigid posture, isn't actually caused by the paralyzed muscles.
It's caused by the healthy muscles pulling wildly without any brakes.
That is the secret to decoding every single nerve deformity. You aren't looking at what's broken, you are looking at what is still working unopposed.
Wow. Let's apply this tug-of-war logic to a catastrophic failure of the upper grid, an upper trunk catastrophe.
Specifically, the violent tearing of the C5 and C6 nerve roots.
This is classically known in medical history as Erb-Duchenne palsy, or simply Erb's palsy, named after the neurologist who first mapped the circuitry failure back in the 1800s.
The mechanical cause of Erb's palsy is a violent, extreme separation of the head and the shoulder.
And it is most tragically seen during complicated childbirth, specifically a condition called shoulder dystocia.
Let's walk through the mechanics of that delivery. The baby's head is delivered out of the birth canal, but the baby is large, and its shoulder gets physically wedged hard behind the mother's pubic bone.
The baby is stuck.
The obstetrician, in a desperate attempt to free the child before it suffocates, applies lateral traction to the baby's head. They pull the head sharply away from the stuck shoulder, stretching the neck to a severe angle.
And underneath the skin, those scalene muscles part, and the C5 and C6 nerve roots are stretched beyond their elastic limit.
The cables snap.
You can also see the same mechanism in adults during high-speed trauma, right?
Oh, absolutely. A motorcycle rider is thrown over the handlebars, they land squarely on their right shoulder, and the impact violently bends their head sharply to the left, ripping the upper trunk of the brachial plexus.
Okay, so C5 and C6 are dead. The upper trunk is destroyed. Let's look at our wiring map. What major nerves just lost their power supply?
3 critical cables are instantly offline. The suprascapular nerve, the axillary nerve, and the musculocutaneous nerve.
Let's figure out what that tug-of-war imbalance looks like on the patient. Let's build the waiter's tip posture piece by piece, starting at the shoulder.
Because the suprascapular and axillary nerves are dead, the supraspinatus and deltoid muscles are paralyzed.
The brain completely loses the ability to abduct the arm. It cannot lift the arm away from the side of the body.
The abductors drop their end of the rope.
So who wins?
The adductors. The powerful muscles that pull the arm toward the body, like the pectoralis major.
They are wired from lower down the grid, so they are perfectly healthy.
Right. With no opposition, the pectoralis major yanks the arm aggressively and permanently tight against the rib cage. The arm is pinned to the side, adducted.
Okay, the arm is pinned. What about rotation? Does it twist?
Yes. The dead suprascapular and axillary nerves also power the infraspinatus and teres os minor.
Those are the muscles responsible for external rotation, right?
Yeah.
Like twisting your arm outward, like winding up for a backhand tennis swing.
They're offline, so the external rotators drop the rope.
Which means the massive internal rotators, again, the pecs and the lats, they win the war. They forcibly twist the upper arm inward, rotating the whole humerus tightly toward the belly.
Pinned to the side and violently twisted inward. What about the elbow joint? Well, we lost the musculocutaneous nerve. That means the massive biceps and brachialis muscles are dead.
The flexors, the benders of the elbow, have dropped the rope.
Which means the massive triceps muscle on the back of the arm wins the war.
Powered by the radial nerve, which is drawing enough backup power from C7 and C8 to still function.
Exactly. The triceps yanks the elbow into a locked, rigid, perfectly straight line extension.
And there's one final twist.
The biceps muscle isn't just an elbow bender, it is also your primary supinator. It's the muscle that turns your palm face up like you're holding a bowl of soup.
With the biceps dead, the supinator rope is dropped.
The pronator muscles in the forearm win the war. They twist the forearm inward, turning the palm permanently backward.
So adducted tight to the rib cage, internally rotated, elbow locked rigidly straight, forearm twisted so the palm faces backward.
If you act that out physically right now, it is exactly the subtle, hidden posture of a maitre d' or a waiter holding their hand low behind their back, waiting for you to slip them a cash tip.
The waiter's tip posture. a devastating mechanical cascade stemming from just 2 broken wires in the neck.
But here's the most fascinating, completely counterintuitive part of the physical exam.
What's that?
If you look at that baby lying on the table with their arm rigidly locked in that terrible posture, look at their hand.
The hand.
The tiny fingers are wiggling. The baby can grip your finger. The hand works perfectly fine.
Wait, really? The whole arm looks totally ruined.
Because of the brilliant segregation of the grid, remember the map? The hand and the fingers are predominantly wired by the lower trunk, C8 and T1.
Oh. During a difficult delivery, the neck was stretched, ripping the top cables.
But the bottom cables, the lower trunk, weren't stretched at all. They are perfectly intact.
So the upper shoulder and elbow are a paralyzed war zone. But the delicate machinery of the hand remains fully operational.
It is incredible how localized the destruction is based purely on the angle of the stretch.
Which perfectly sets up the exact inverse scenario. What happens if the trauma comes from the opposite direction? Lower trunk catastrophe.
The ripping of C8 and T1.
This is known as Klumpke's palsy, right?
Yeah.
Named after Augusta Dejerine Klumpke, a brilliant pioneering female neurologist who mapped this specific lesion in 1885.
The mechanism of injury here is the exact biomechanical opposite of Erb's palsy. Instead of the head being pulled away from the shoulder, forcing the arm down,
The arm is violently, forcefully yanked straight upward, high above the head.
right.
What's the real-world scenario for that?
In obstetrics, it happens during a breech birth, where the baby is coming out feet first. The arms can get flipped up over the baby's head. As the doctor pulls the baby out by the torso, the arms get caught on the mother's pelvis, and the arm is violently hyperabducted upward.
And in an adult.
The classic textbook example is falling out of a tall tree. As you plummet toward the ground, you reach out and manage to hook one hand onto a branch.
Your entire body weight drops, but your hand holds on.
The immense kinetic energy violently rips your arm straight up past your ear, stretching the armpit open.
That intense upward traction pulls right on the bottom of the grid. It specifically tears the C8 and T1 roots right out of the spinal cord.
Now remember our map. What do C8 and T1 primarily supply?
They are the exclusive power source for the ulnar nerve, and they provide the vast majority of the crucial fibers for the median nerve.
They power the maestro and the powerhouse, the fine tuners.
So the shoulder might move, the elbow might bend, but the hand.
The hand is rendered a catastrophic wasteland. You lose massive amounts of the tiny intrinsic muscles deep inside the hand, the lumbricals, the interossei, the delicate muscles that balance the fingers.
And the tug-of-war imbalance here creates a horrific deformity. Because those tiny internal hand muscles are dead, they drop the rope. Who wins?
The massive, thick, powerful extensor and flexor muscles located way up in the forearm. Because they are wired by higher-up roots, they're completely healthy.
But they are incredibly clumsy.
Without the tiny intrinsic hand muscles acting as shock absorbers and balancers, these massive forearm muscles completely overpower the joints of the hand.
They violently yank the main knuckles of the hand backward into rigid extension, while simultaneously curling the fingertips tightly inward into extreme flexion.
The hand is pulled into a permanent, rigid, curled hook. It is clinically known as a severe claw hand.
The patient loses all fine motor control. They cannot pinch, they cannot write, they cannot grasp a cup.
The arm functions like a crane, but the claw at the very end of the crane is permanently broken.
It is utterly devastating. The contrast between Erb's and Klumpke's is the ultimate proof of the grid's precision. Pull the cable down, the shoulder dies. Yank the cable up, the hand dies.
Exactly.
Okay, we've covered an immense amount of conceptual and anatomical ground today. Let's take a breath and sort of summarize this whole journey through the machinery.
It's been a ride.
We started at the power plant in the neck, the 5 roots, C5 through T1, physically squeezing their way out between the scaly muscles.
We watched them merge into 3 massive trunks resting on the first rib, acting as biological backup generators to ensure survival.
We saw them logically divide into benders and straighteners right behind the collarbone, sorting out the flexors from the extensors.
We watched them recombine into 3 thick cords wrapped intimately around the throbbing axillary artery deep in the armpit.
And finally, we traced the terminal lines, the axillary wrapping the humerus, the radial spiraling down the back of the arm, the musculocutaneous piercing the bicep.
The median squeezing through the claustrophobic carpal tunnel, and the ulnar maestro vibrating against the funny bone.
All acting together to maintain the delicate, invisible tug-of-war that keeps your joints balanced and functional.
It is a dizzying amount of anatomy, but it is not random. It is deeply mechanically logical once you actually see the pattern of the wires.
And this matters to you, listener, right now in the real world. The next time you bang the inside of your elbow and hit your funny bone, which you now know is physically crushing your ulnar nerve against the medial epicondyle.
Or the next time you wake up at 3 a.m. with your hand totally numb because you curled your wrist inward and spiked the pressure in your carpal tunnel.
You aren't just feeling random pain anymore. You now possess the architectural blueprint. You can close your eyes and visualize exactly which yellow cable is being pinched, stretched, or starved of oxygen.
Understanding the anatomy takes the terrifying mystery completely out of the machine. But paradoxically, the deeper you understand it, the more it instills a sense of profound, almost unsettling awe.
What do you mean by unsettling?
Well, think about the evolutionary baggage of this whole design. Consider the human hand. It is capable of vast contradictory extremes.
It possesses the brute mechanical strength to crush a rock or shatter a board.
Yet it has the microscopic vibrating precision required to play a Chopin sonata or perform a 10-hour open-heart surgery.
True.
Every single one of those microscopic movements, every delicate twitch of a muscle fiber, is entirely puppeted by a few wet, fragile electrical cables originating over 2 feet away, way up inside your neck.
Yeah, that is strange when you think about it.
If you were a software engineer or a roboticist designing a multi-million-dollar surgical robot, would you ever design it this way? Would you place the central processing hub and the main breaker box so far away from the mechanical end effector?
Never. You'd put the battery and the chips right in the hand.
Exactly. And you certainly wouldn't route the most critical, delicate data cables through such high traffic, incredibly vulnerable kinetic bottlenecks.
You wouldn't squeeze them between violently contracting neck muscles.
Or stretch them tightly over a sharp first rib right next to a lung.
Or spiral them totally exposed around the shaft of a bone meant to take impact.
Or jam them through a cramped, bone-lined carpal tunnel along with 9 grinding tendons. From a purely modern engineering standpoint, the brachial plexus seems like an absolute nightmare.
It seems like a recipe for constant daily failure.
Yet, despite all the vulnerabilities we spent the last hour discussing, despite the traps and the choke points and the evolutionary compromises, it is a miracle of biology that this fragile, wet circuitry works as flawlessly as it does for the vast majority of our lives.
It really makes you appreciate the fact that you can simply reach out and turn off your media player right now without even thinking about the millions of electrical signals firing down your arm to make it happen. Thank you so much for joining us on this deep dive into the brachial plexus. We hope you take this map with you, feel the architecture in your own limbs, and keep diving deep into the absolute wonders of your own anatomy.